It is arterial blood gas analysis. So the thing is that it's not that complex topic, but when we are doing our day-to-day practice, no one is having clear understanding. It's honestly, we all have to accept that. Being anesthetic, most of the time we have to do that. So it may be the reason that we are doing it and every day, but it won't be, even though it's a common topic, we all are not very much familiar. So during my lecture, my learning objects, understand the physiology of acid-base. This is a big topic, right? So we can't study or we can't understand that what is ABG without having the proper physiology. But I am not going to discuss that physiology here because it takes long time. So I assume that your undergraduate and your university level, you are having some very good physiology knowledge. I will touch little bit of, but I am not going to discuss that what is acid-base balance and what is the physiology. So apply systemic ABG interpretation. It's a stepwise approach. It's the easy way to, when you are dealing with the blood gas, when you are going with that in my next slides, I will discuss. So always follow the same structured stepwise approach. Then you are not going to miss, or it's easy to make your diagnosis. And there are situations sometimes that blood gas is not very clearly highlighting the disease, that ongoing situation. So we categorize those things as mixed disorders. So we will discuss what are the type of mixed disorders and avoid common interpretation errors. So these are machine-related findings, parameters. So not only for the blood gas, so any your clinical assessment, clinical data always correlate with the clinical presentation of signs and symptoms and other clinical presentation of the patient. So why ABG matters in clinical practice? So even though we as anesthetists or intensive care doctors, it's a very common or day-to-day investigations we are doing, but it doesn't say that it's not that the test we have to do in the ward setup. But only problem is sometimes we are not selecting the correct patient. So being a very common test even, we have to select the correct patient. But in ICU practice, for the ICU management decisions making, we are usually doing it daily in every patient. So essential indications for the blood gas, we are measuring that oxygenation. As we all know that oxygenation is the adequacy of the tissue perfusion, oxygenation at the mitochondrial level. So there are many parameters you can assess oxygenation, pulse oximeter, saturation, partial pressure of oxygen, right? So ultimately that to get a very clear understanding the oxygenation in a critically ill patients, we are doing blood gas. Other thing is ventilation. It's going hand in hand, oxygenation and ventilation. So why we are ventilating, why we targeting adequate ventilations to target adequate oxygenation. And the other main aspect is not something directly related with oxygenation, but it's always is combined with that metabolic state. As we know that acidosis, alkalosis, that those conditions, we are going to assess doing blood gases. So once we do assessment that ABG, then only we can make that our decisions, clinical decisions, how we can optimize, so how we can correct that patient's rearrangement. So ventilator adjustment, shock management and sepsis care, those things mainly depend on arterial blood gas analysis. And life-threatening acid-base disturbance. For that also, they depend on the pH and bicarb level. We are discussing that in future slides. So we have to do blood gas analysis. But why I have highlighted that last sentence in red, it should be ordered only when clinically indicated. Avoid overuse. This is what myself also having that confusions when I starting in our medical career. So many terms you can hear in every day if you are visiting ICU. I should honestly tell that it's rarely I can see that junior doctors are visiting to see ICU to see their patient. Right? I suppose that I hope hereafter, after my lecture, they will come. Because the thing is that I will take that I am in a hurry to go, but still because I am meeting you is one occasion. So thing is that you are what mean that you are assessing or you are managing patients not critically. Then at this one situation, patient is got critically ill, then you are transferred into the ICU. Then we are sending back again, patient is stable to be stay in a ward. But there's a gloomy time. Right? This is the most critical time why patient got critically ill and what we have done in the ICU. That clinical experience or knowledge is not going to share with you because you are not visiting. Don't get angry with me, and I'm not criticizing, but our junior doctors, I rarely see it. My colleague Kishan sir will agree. In nowadays, we have to go to the ICU and we have to beg in ICU senior most what is happening because it's a new place, many monitors, alarms and things. But being a HO level, you are not familiar. But still, you have to come and see. This is the only place. Then, if you have come, you know that what is happening with the blood gases. Right, that's why I'm telling. So try to have. I know that you are busy, maybe clinic casualties, but it is part of your training. We have to come in ICU and see only 10 minutes in a day and summarize to a consultant. This is what's happening in your patient because patients are belongs to all of us. We are giving critical care, but still patient is under your unit. Right? It is so your right also. It's your part of your duty. So primary disorder, anion gap, compensation, delta ratio, many words. Don't get confused. I will try my best to have some simplified explanation. So first of all, that how we are going to interpret blood gas, you should know how to collect blood samples for blood gas. So indications, main indications to assess oxygenation, ventilation, and metabolic state, as I said. There are few contraindications. Right? It may be contraindicated in your level, but saying that, but you, if you have to do with your expert advice or with your senior advice, sometimes you have to proceed. But keep in mind that local site sepsis. We are going to get blood from radial site is a normal, the commonest site that we are pricking the patient radial artery. So if there's local sepsis, we are not going to do. Right? And AV fistula. Right? So there are many patients that in AV fistula, so we are not going to puncture, select that site to do the blood gas analysis. And severe coagulopathies. Right? And negative Allen test. I hope you all know that Allen test. Raise your hand that who are not knowing Allen test, junior doctors. Not I am not asking that one first. Not knowing, no knowing Allen test. One is doing it. No one is doing it. In a day, you will get in a trap, and you are, it's not something simple. You are all assets you earn, you have to pay in a legal background because you have contributed to lose the hand. Right? Allen test is you have to make sure that the pharma collateral supply of a hand. Right? Why we are doing radial? It's a naturally wonderful site having collaterals because ulnar and radial both arteries are giving arch. So if you are doing radial puncture and if you have lost or whatever the congenital or some other secondary cause, if you have compromised, that patient is compromised ulnar supply and you are making a thrombus in radius, you are going to lose this wrist. Right? So go and read that. I'm not going to tell that what is Allen test, but you have to know how to do Allen test and no arterial radial puncture if you have not done Allen test. Site selection, radial is the commonest site. First choice, femoral, emergency shock. You know that in a shock, you can't palpate radial pulse. What is the minimum blood pressure you need to palpate radial pulse? Any idea? Is 60. Below 60, you can't palpate radial pulse, right? So say patient blood pressure is it's not there as hard and fast rule. Maybe obese patient, even in 70, you can't palpate. So in such situation, you can prick the femoral artery, right? So emergency in shock femoral, but any other elective patients, radial is the commonest and safest site being that collateral supply, having that collateral. Brachial is preferred, but sometimes you have to puncture. Preferred arterial line. So if patient is already with the arterial line, it's the most easiest, comfortable way. You can withdraw blood from the arterial line. We are using 1 ml syringe. The important thing, you have to withdraw 1 ml blood, right? That blood gas machine aspirate only 0.3 to 0.4, 0.5, less than 0.5 ml, tiny volume. But it doesn't say you have to get a sample in that particular volume. You have to get it up to 1 ml. Right? It's a recommendation. I have seen some blood gas, maybe the practical difficulty, but it's coming with 0.5 ml, 0.4 ml. It is not correct. Right? You have to aspirate at least 1 ml to insulin syringe. So definitely that compulsory you have to heparinize, but you are not going to keep any heparin volume in the syringe, right? You get heparin 0.5 or 1 ml to syringe and flush it out completely. Only the bare space in front of the syringe and the needle connected side, that is enough, right? Why? What's the problem with having heparin excess volume? What type of error you are going to get? Those things I did mention in the lecture, right? Heparin, alkali or acidic substance. දරුවනේ දැනගෙන කියන්නේ නැද්ද? It's acidic, so your test, whatever pH is going to change. If you are having, comparing to the blood volume, you are having excess volume of heparin, is your pH assessment may be erroneous. Then send analysis as early as possible, as soon as it should be in the bedside. That if you are with more earlier is more accurate. Right? Why is that also? Say if I put a correction like this, what type of error is getting into that? If you get a 30 minutes delay sample, oxygen and carbon dioxide, what will happen? Right? RBCs are live cells, right? So delay in time, it's going to use that oxygen within the blood. So you can get the hypoxic, erroneously hypoxic oxygen partial pressure, low oxygen partial pressure with high carbon dioxide, right? So how we are going to that? If any reason, if you have to delay that you are analyzing, you have to freeze it, right? Adequately, you can read those things in that any textbook or the article is giving. So withdraw blood sample, keep it with ice, and you have to cover the needle tip not to get any contact with the atmosphere, right? So if you get contact with the atmosphere, what happens is atmospheric oxygen is higher than our intra-arterial oxygen. So diffusion can make some external atmosphere oxygen to the blood sample. That's also kind of error. So you have to cover the tip. That's why we are using rubber lid, that bottle cover. So sometimes I have seen that the needle has pierced through, and that opening is outside the that rubber lid. It's not correct. You have to completely seal that tip, right? Sampling protocol. Same thing that what I have discussed. So we'll get into the exact that topic that what we are going to discuss with the APG analyzing. So these are very common that familiar parameters. So mainly we are in a blood gas report. If you are seeing that our real blood gas reports, there are many directly measured and calculated parameters, right? Blood gas APG analysis is a big topic, right? You can discuss with few hours, but your day-to-day clinical practice in your level, don't get confused with that all the parameters and what we are. Even our level, we are not going to assess everything. That there are some key factors, key components to assess. So these are the things I am going to discuss here. So pH, we are going to assess an arterial carbon dioxide partial pressure, bicarbonate, oxygen, lactate, and base excess. So these are the normal value we are going to interpret when we are interpreting that we are going to use. So we know that neutral pH, our in vivo vitro neutral pH is 7, right? 14 and 1 in between, 7 is the neutral. But in our physiological, in vivo environment, 7.4 is the middle point, right? It's not the 7. So 7.4, 0.05 less than 0.05 higher than that, it comes as 7.35 to 7.45. So this is our normal range. So please keep in mind, this is our normal range. Always that we are not going to categorize, so classify patient alkalotic or acidosis within this range, right? When you are interpreting, I will explain it clearly. So PaCO2 is a partial pressure of carbon dioxide. It's 30, sorry, it's not 36, it's 35 to 45. Bicarb 22 to 26 millimole per liter. Some books say 28, but it takes us 22 to 26. Partial pressure of oxygen 100 is a normal healthy person, but up to 80 is not a clinically significant hypoxemia, right? You can consider even with aging also, we are going to have that 80-85 partial pressure, like that elderly people like us or me, not that young audience. Lactate plus or minus lactate 2, less than 2 is normal, but it's more than 2 is abnormal. Base excess again plus or minus 2. Indication to blood gas, right? Again, that the same thing that if we list the indication, the acute respiratory failure we are doing to assess oxygenation and ventilation, right? Assessing carbon dioxide and oxygen. Shock and sepsis, we are assessing, again, oxygenation is a part of shock and the lactate mainly. Our Dr. Udan, our consultant nephrologist, will agree that DK, metabolic acidosis, AKI, I didn't put that AKI here. It should be there. And acute kidney injury, we are doing blood gases. And ventilated patients, to assess ventilated parameters we need. Altered consciousness, again, we are doing that post-intubation and peri-arrest patients. So these are the clinical situations we are commonly doing. So systematic interpretation, 5 steps method. Right, we are discussing that to follow in each and every patient's blood gas. Then I hope that at the end of the lecture, you will be an expert to interpret blood gases. So how we are going to proceed? I will show you that the later. So first thing is pH, right? We have to see pH. What is the pH? So as I said, it's 7.35 to 7.45 is normal. Beyond that, out of this range, we are going to classify as acidic or alkalotic. There are a few terms, acidemia, acidosis, right? I will tell that what are the differences of these. So then once you see the pH, you have to same time see bicarb and carbon dioxide, right? Assume that you are having 2 eyes, so one eye is to the carbon dioxide, other eye goes to the bicarb. It's the same parallel line you have to see. Right? So once you see pH, you have to label whether it is acidotic or alkalotic or normal. Right? Then you are going to compare what factor. Atkotan seats at the other Israel. Another Israel. Right? So once you label that whether it is acidosis or alkalosis, then you have to see carbon dioxide or bicarbonate to see which component is parallelly goes, so contributing for that primary defects. Right? See that, you know that carbon dioxide 35 to 45 normal, hypercarbia is more than 45. Everyone knows that hypercarbia causing acidosis, hypocarbia causing alkalosis. So if you find pH is acidotic, and your carbon dioxide is more than 45, your primary label is it's respiratory acidosis, right? And acidotic pH, your bicarb is less than 22, right? It's a depleted bicarb, then it is metabolic acidosis. Likewise, it's not a difficult thing. That's why I am just telling it in fast. So when you are completing that pH, second primary and primary disorder. From that second step, you have to label it as what is the primary dearrangement of this blood gas. Then the compensation. This is little bit of complicated or complex thing. We are going to discuss that. But third step is the compensation. If once you primary disorder detected, you can assess with further parameters whether it has compensated or not. Once compensation is there, you have to make sure partially compensated or fully compensated, right? We'll see that. Then another parameter is anion gap, oxygenation, and mixed disorders. Right, it's step 1 pH. So less than pH 7.35 acidemia. So what is acidemia and what is acidosis? It's the same concept or different? What is uremia? That emia, once it combined with the word, is something to do with blood. So when bacteremia, when the bacteria in the blood, it is bacteremia. So acidemia in acid in blood, it doesn't say any pathological state. You can have acid in the blood, right? But acidosis is the pathological conditions, disease, right? Respiratory acidosis. We are not telling that respiratory acidemia. right? We are not telling metabolic acidemia, it's metabolic acidosis. So when there's a pathology, it's disease causing some dearrangement, so adding acid or adding losing bicarb or whatever, then it's some state of that dearrangement is acidosis. But isolated or the clear alkali or acid appearing in blood is acidemia or alkalemia, right? So normal disorders, the normal conditions, as I said that 7.35 to 45 is normal, right? One possibility is normal, patient is completely normal. Other possibility is having some dearrangement and compensated, right? You can clearly see that in assessing the other parameters. So you can have a normal pH range in a patient, maybe not having any alkalemia or acidemia causing acidosis or alkalosis, or having primary disorder and completely fully compensated again within the normal range. Right? These are the two situations. That's why it's possible normal or possible mixed disorders or compensated. Am I confusing you too much? No. At the end of the lecture, if I'm going to lose the things you are having that whatever before coming the lecture, it won't be nice. Right. So step 2, primary disorder. So you have to keep in mind 4 disorders. Right? Broad categorization, 2 disorders, respiratory and metabolic. But each respiratory and metabolic is having alkalosis and acidosis. Right? So it's easy. Right? So increase the any dearrangement or how we are going to label it as respiratory if carbon dioxide is contributing for the primary dearrangement of the pH is respiratory. So hypercarbia or increased carbon dioxide in the first line, pH is less acidic. So it's respiratory acidosis. Later we'll see it's acute or chronic. When carbon dioxide is low, pH will go up because it is alkalosis. So pH is more than 7.45 is respiratory alkalosis. When bicarbonate is low, below 22, it is acidosis. pH low, it is metabolic acidosis. When bicarbonate is high, it's alkalosis. So it's metabolic alkalosis. That's how we are going to make your primary disorder. Step 3, compensation. How we are going to compensate? I think God, when we are creating all that human being or that all living creatures, he is the most expert physiologist, anatomist, and everything. Because he has arranged, he have done everything, but I am confused in one thing. It's not belong to this lecture, so I am not to discuss. God has made a big mistake in one area, right? But all other things are matching for our living, right? Safeguarding. So this compensation, our metabolic environment in the body is going to balance with lung and kidney. His honor is going to the Udana, sir, looking after our kidneys, right? Draupadi Madam is not there, no? Right? So it's a what we call this open, both ends open reaction. Right? Carbon dioxide, water, that's common formula, you know, make carbonic acid, then bicarb and hydrogen ions. So bicarb and hydrogens you can exceed or reabsorb in the kidney level. Carbon dioxide you can eliminate from the lung. So very rare situation you are going to shut down both ends of the human body or the whatever the animal. So when you are having pathological situation in a kidney, you can compensate with the lungs. When you are having problem with the lungs, you can compensate with the kidney. That's what we are telling respiratory and metabolic compensation. So both ends, sometimes COPD patient having AKI is a different scenario, complex scenario. Right? So how we are going to compensate? When we are having respiratory, that means carbon dioxide. Carbon dioxide is some dearrangement. So easiest way how you can have an idea whether that patient has compensated or not, we have to make sure what is the primary disorder and find the other compensatory site. So if carbon dioxide is primarily dearranged, compensation should be in the bicarb. So if bicarb is still in the normal range, within normal range, no compensation. Right? You know by heart that 22 to 26 is the bicarb normal. So, but with the primary respiratory dearrangement, if bicarb has either way is changed, now the compensation has initiated. So this is a simple way. even though that word is complex like compensation, it's not a big calculation you need. You just see the primary parameter and find is what is the primary disorder and what organ is going to compensate. And find that the bicarb or carbon dioxide, those are the two ends, whether these are in the normal range or change from its, move from the normal, within out of the normal range. Right? This is the only thing. Important thing is, sorry, another mistake, right? That kidney is slow, lungs is fast. I purposefully put that anyone is noticed and let me know, but no one is noticed that. No, it's my own mistake, right? It's clearly, get it clearly, right? Kidney compensation is, no, I am correct. Right, sorry, I am confusing. Right. Yes, metabolic, no, that compensated is fast. I have done it correctly, sorry. Yeah. Kidney compensation is slow and lung compensation is fast, right? So always ask appropriate compensation, if not mixed disorder. When you are interpreting blood gas, always make sure whether compensation is there or not, right? So if you are getting a patient with the respiratory compensation, more or less that compensation is started because respiratory compensation is within minute. But renal compensation is not that quick. It takes hours to days. Right. These are little bit of advanced stuff, right? But if you are going to analyze blood gas reports, these things you should know, right? But as I said, that to identify compensation, whether compensation is not available or happen or not, that is enough, that previous slide. So what are the advanced formulas? Metabolic acidosis. In a patient with a metabolic acidosis, that means pH is low, bicarb is low, primary metabolic acidosis. When the metabolic acidosis is there, body is going to compensate with respiration, right? So you can find out, this is not a good time for a lecture, no? This type of lecture. Too academic and I can't make it as another interesting way. I'm going to give some practical that case scenarios. Then each of you, I am going to point it out my finger to you, then you have to wake up. Right? Before lecture, it's not nice to point out because we are not knowing things. So metabolic acidosis, Winter's formula, the name is Winter's formula. What we are going to do is we are going to find expected carbon dioxide. It is not the carbon dioxide appear on the blood gas, in other words. So if patient has that acidosis level, what should be the patient carbon dioxide if patient has compensated, something like that. So how we are going to calculate? You have to get the bicarb from that blood gas, multiply by 1.5 at 8. Right? Then you are going to get a value. This is expected carbon dioxide. So that expected carbon dioxide is matching with your measured carbon dioxide in the ABG. That means patient has start compensated, or it is the carbon dioxide should tally with that ongoing acidosis. Right? If there's acidosis, definitely carbon dioxide should be washed out. Right? Adding carbon dioxide is acid. So patient is metabolically acidosis. If we allow patient to do own ventilation, patient is going to hyperventilate, right? Then the carbon dioxide, this calculation always come less than 35, right? So if carbon dioxide should be 20 expected, but still the blood gas it's 35, that means patient has not compensated. Maybe respiratory failure even, right? We don't know. We can't say the patient is normal and not compensating. Maybe the patient is failed ventilation. Whatever reason, that's how get it. Metabolic alkalosis is again expected carbon dioxide. It should be higher than the 35. Normal range, 45. That's how it comes as bicarb into 0.7 plus 20. Acute respiratory acidosis and chronic respiratory acidosis, easiest ways to keep in mind, each 10 millimeters mercury change of carbon dioxide, right? Say now it is 55 from 45, then 10 millimeters mercury, bicarb is going to change by 1 in acute condition. Chronic conditions 4, right? Don't get confused. I will put a chart, then you will familiar with that. Right.